Hello, and welcome to this training entitled Caring for Patients Who Experience Domestic Violence. This training is intended for individuals providing care to patients in a wide variety of healthcare settings. It is appropriate for medical and clinic staff in various roles, from RNs to MAs to physicians to front desk staff. If you interact with patients receiving healthcare in any way, this training is for you. We will provide a basic orientation to domestic violence and illustrate why and how you can screen for domestic violence amongst the patients that you serve, and ultimately connect those who are experiencing domestic violence to resources that provide help, support, and healing. This training was created and delivered by 4 women, including Miss Natalie Hayden, who has experienced domestic violence in her lifetime, but is now thriving in spite of her experience. Ms. Shamika Washington, who likewise has experienced domestic violence in her lifetime and is likewise thriving despite her experience. Both Natalie Hayden and Shamika Washington serve on Sojourner Family Peace Center's Voices Committee, which is a committee of domestic violence survivors who have decided to give back to that community by advocating and adding their voices to initiatives and projects designed to serve folks who have experienced domestic violence. Ms. Liz Marquardt is a domestic violence professional at Sojourner Family Peace Center in Milwaukee, Wisconsin, who has over 30 years professional experience advocating for and supporting victims of domestic violence. And myself, Dr. Erin Schubert, who leads the research and program evaluation efforts at Sojourner Family Peace Center in Milwaukee and helps the organization and its community partners use data and science to provide the best possible care to those experiencing domestic violence. This training is split into 2 different days. Day 1 will be presented in this pre-recorded video module. Day 2 will be delivered live to allow for real-time engagement and skills practice. Today, in day 1, we will define your role when it comes to screening for domestic violence, provide some introductory domestic violence 101 material, review the impact of domestic violence on children, and hear as Natalie and Shamika share their perspectives and experience as survivors and thrivers. After you have completed both days of this training course, you will understand domestic violence and coercive controlling dynamics, hear survivors' perspectives and experiences on the importance of screening for domestic violence in healthcare settings, learn the best practices for screening for domestic violence in healthcare settings, and finally, you will learn, I have been experiencing this, you will learn how to respond in the moment and how to connect them to ongoing resources for support and healing. This is a training on domestic violence. The topics that we'll be talking about in this training are oftentimes hard to hear, they're hard to think about, hard to talk about. However, we believe in talking frankly about domestic violence and its impact to promote understanding, empathy, and ultimately action. At the same time, we recognize that a lot of people come to this work because of their own traumatic experiences. You are your own best expert at yourself. You can understand what you need to take care of yourself, and we invite you to do so. If you need to step out for a break, pause the video to take care of yourself, please do so. Further, and really importantly, if you are currently experiencing abuse, or if you have in your past, please know that all of the resources that we talk about in this training are there for you too, and you deserve to be safe. You are attending this training today in recognition of the vital importance of your role and the role that you play in the lives of the domestic violence survivors that are among the patients that you serve. Whether or not you are aware of it, many of the patients that you serve in your clinic are experiencing domestic abuse or intimate partner violence. Survivors who tell you about that abuse are coming to you at a critical juncture in the road. Getting help and leaving an abusive relationship is the most dangerous time statistically for a victim. And this is a danger that victims oftentimes sense intuitively. Your role at this critical fork in the road can either lead them back to the isolation, shame, and continued abuse in their relationship, or if it's done well, it can empower them to walk down the road towards safety and healing. We will walk through techniques in this training that will help you guide patients to the road of safety and healing. So what is your role specifically? Or rather, first, we'll review what your role is not. First of all, we're not asking you to be all things to all people. You have a very specific role in your clinic or in your healthcare provision area, and we're not attempting to usurp that role. We're also not asking you to become a DV expert, right? You'll receive some basic introductory information about DV to understand those dynamics a bit better, but there are other professionals whose entire career is dedicated to understanding and advocating for domestic violence survivors. We're not asking you to become that. You're not there to provide ongoing support for all needs surrounding a domestic violence survivor's experience. And perhaps most importantly on this list, I think, is to understand that it is really not your role to determine the validity of anybody's abuse claims. So what is your role then? Your role, first and foremost, is to be a listening ear. This could be the survivor's very first time saying this out loud, right? Reaching out to anybody or telling anybody about what has happened in their relationship. This is scary, sometimes humiliating, sometimes terrifying, but always important moment for them. It is also your role to be a door opener, right? In a metaphorical sense. You should be opening the door for survivors to talk about what they've been through and then to connect them to that ongoing support that they might need in their situation. That connection might look like giving them brochures or resources to take home or to think about, or it might look like referrals to additional services and additional professionals who can help them in an ongoing way with those domestic violence related needs. I would say a third piece of your role is to be a believer, right? We talked about how it's not your role to determine the validity of somebody's claims of abuse. There is not a single way that a domestic violence survivor looks. There's not a single way that they're going to act or they're going to talk. Anybody could be experiencing these dynamics in their relationship. And again, your role is a healthcare provider in some capacity. You're not a judge, you're not a law enforcement investigator, you're not a district attorney. So meeting a survivor who discloses abuse with an attitude of belief and support and empathy can make all the difference. Finally, if you play those other parts of your role well, I think you can be that bridge to safety and healing for the domestic violence survivors that you serve. So you might be asking, or maybe when you heard that this training was coming, is, hey, we're a healthcare provision. We do healthcare, right? We focus on physical healthcare, biomedical issues. So why is domestic violence an issue that we should address in this healthcare setting? And I think one of those reasons, of course, is to be that door opener that we talked about, that allows survivors to disclose what's happening and to connect to help. So I would say, despite an increasing awareness in our society in general about the prevalence of domestic violence and the negative impact that it can have, still, most victims have not been screened for in any capacity or really asked about their experience at all. In fact, when we talk to both adults and youth survivors of domestic violence, we hear consistently that they actually were rarely asked about their experience, and it was really only ever in reaction to something really serious happening. So maybe law enforcement had to get involved, or perhaps they had such a bad injury that they needed to be treated for like an acute injury resulting from an assault in an ED. And especially in our community in Milwaukee, where we're coming from, and many other communities across our country, there are established screening and referral protocols, for instance, with many law enforcement jurisdictions. So This is, I would say, a necessary step in supporting survivors who are interacting with law enforcement, but it is by definition really a reactionary step, right? It's a reaction to abuse that has already gotten severe enough that the police are showing up. And we believe in the importance of opening doors for survivors to connect to resources and support much earlier in that trajectory, before that abuse gets so bad and so serious and life-threatening that law enforcement must respond. So let's walk through an example of what a relationship timeline might look like today in a world in which asking about abuse and connecting to resources really only happens in reaction to serious incidences occurring. So in this timeline, two people meet, they fall in love. Over time, things get serious and she decides to move in with him. Few more months go by and she finds out she's pregnant. He seems excited at first. He tells her that she'll be an excellent mother, that he will support her and the baby, and that there's really no need for her to work anymore. She quits her job so that she can stay home and take care of the baby. When her sister expresses concern that she quit her job with a baby on the way, he tells her that her sister is no good for them. She doesn't want what's best for them as a couple and what's best for them as a growing family. She should not talk to her sister anymore. He also starts to get suspicious and jealous of her other family members and friends. To avoid the drama, she withdraws from those social connections. The tensions, the argument, the jealousy and controlling behaviors begin to get more and more frequent as the pregnancy progresses. After 40 weeks, baby is here. In the hours and days after baby's birth, she daydreams about her happily ever after. Surely all of this tension and this drama and this stress is going to go down now that they're this perfect little family, right? But it doesn't. He continues to be jealous and controlling. She's walking on eggshells, which is especially difficult given the new role and responsibility of being a new mother on top of the way that her relationship is going. The controlling and emotional abuse turns physical. The fights get so bad that neighbors overhear. During a particularly loud and brutal incident, the neighbors call the police. Now, there she is, a new mom, entrapped in an abusive cycle with no easy options. The police, because of the partnerships that we've built, offer to connect her to a domestic violence advocate over the phone. That's the current call for help. Now, let's think about this relationship timeline again and see how things could look a lot different if we implement the universal screening and connection to resources much earlier in this trajectory. So now, let's imagine she just found out she was pregnant again. Imagine the clinic where she's receiving her prenatal care has decided to ask all patients that they serve about controlling and abusive behavior that they might be experiencing. She's well dressed, she's well spoken, she reliably attends her appointments, even though she doesn't look like the typical domestic violence survivor. The nurse follows protocol and she asks the screening questions. She says, yes, this is happening in my relationship. This opens the door much earlier in a survivor's journey to connect with support and healing, potentially avoiding the more severe manifestations of abuse later on. And this door to opening support much earlier in a survivor's journey, this is the power that you have by screening for domestic violence with each patient that you serve and connecting those who are experiencing abuse with resources and support going forward.
So now we're going to talk about how we define domestic violence. We're going to define it as a pattern of a behavior used by an intimate partner. It's behavior that causes harm, that results in power and control being centered on the person causing the harm. And we're going to talk about intimate partner relationships, but we're also going to acknowledge that this behavior happens within families and within households. I'm going to use the term victim and survivor rather interchangeably, and I'm going to focus on intimate partner relationships that you're patients are engaged in. This project is about creating possibilities for those who've experienced abuse. We as a community need to create these possibilities with the end goal of interrupting abuse and preventing homicides. Your patients are going to talk about lots of types of abuse, not just physical abuse, but other types of abuse. They may say that their partner is controlling, jealous, or threatening. They may talk about stalking, verbal and emotional abuse, financial and sexual abuse, and property destruction. Let's look at a model created in Duluth, Minnesota by Ellen Pence and Michael Paymar. This visual representation of abuse still resonates today. So back in the 1970s, while we were still developing an understanding of abuse, Ellen Pence and Michael Paymar talked to women's support groups about what they were experiencing. And they also talked to men who were in groups for those who were ordered into classes because of their criminal abuse that had been that had come to the attention of the criminal legal system. So when they talked with these folks, they realized that the physical and sexual violence was really just the tip of the iceberg, and that it held the whole thing together. And the dynamics really resulted in the person causing the harm having control over their partner and all the power in the relationship. They added to this the spokes that hold it all together and give the dynamic power. Those spokes only were put on this wheel if they were experienced and talked about in every single group. So these are the most common tactics that were used at the time. Now there's lots of other tactics that are used. And really anything that can be used to get power and control or to harm a partner could be on this wheel. So let's look a little deeper. Physical abuse and sexual abuse, we're really talking about minor abuse, from pushing and shoving to hitting, slapping, and very lethal and scary violence, including choking and kicking, biting, pinching, restraining, and all types of physical violence, including sexual assault, all types of sexual assault. It holds the wheel together, and the spokes make it more powerful. So emotional abuse is one that you're going to hear patients talk about a lot. That emotional abuse is used to punish them when they don't do what their partner wants. It is used to make them feel badly about themselves, make them feel as though they don't deserve better, and that they're not worthy, and that their partner really is more deserving of care and concern and the resources in the relationship. In particular, the denying, minimizing, and blaming of emotional abuse can be very powerful. The abuser is not taking responsibility for their own behavior. They're saying that the abuse didn't happen or wasn't that bad, or that it was the fault of the victim, which then the survivor starts to internalize that it's their fault. It can include completely disregarding the survivor's feelings, concerns, hopes, and dreams, and wishes. Really, it's very boundary violating. In recent times, the term gaslighting has come into consciousness, and lots of folks talk about being gaslighted. And gaslighting is a term rooted in an old movie, which is meant to make the victim feel as though they don't have a firm grip on reality. So the husband in the movie was turning the gaslights down and denying that the gaslights were being dimmed. So this term describes sort of a behavior that makes the victim of it feel as though they're losing touch with reality, and that they don't know what's real anymore, and question their own reality. So another very powerful tactic of abusers is isolation. Isolation means that the survivor no longer has someone to check out what's happening, to say, is this really abuse? Because my partner is saying that it isn't abusive, or that it didn't happen. So when one is isolated, one has less opportunity to sort of check their version of reality and what's going on. It also means that the partner has much, much more control over not just the view of reality, but sources of information that the survivor gets, and potentially support and help. So if I keep my partner from seeing friends or family, then those relationships deteriorate, and I have less people I can turn to if I decide that I want help and I want to get away from the abuser. So it may have to do with controlling movements, whether or not I can go to school or work or social events. It may be that my partner is turning me against the people who could be potential sources of support, and convincing me that they really aren't good for me, or that they don't have my best interests at heart. And it can be that I am really embarrassed about what I'm experiencing and I don't want others to know. So I isolate myself because I'm afraid they might know what's happening. I'm also really afraid that they're going to judge me and blame me for the situation that I'm in. I mentioned earlier that many patients are going to talk about their abusive partner as jealous. And the jealousy really is tied up in a feeling of entitlement, that I am entitled to my partner's attention, resources, time, and that they really belong to me. So it has a very profound sense of entitlement and possessiveness. Very often there are accusations of infidelity and irrational behavior to try to stop them from interacting with other folks. This particularly can escalate during pregnancy, right? Because if someone who's pregnant is spending all of their time preparing for the new addition to the family, caring for themselves in preparation for giving birth, and thinking about something other than their partner who feels entitled to all of their time and resources, it's seen as a threat to the relationship and to the partner. So lots and lots of ways of control. The control can go as deep as controlling how you speak, how you dress, where you go. And it can happen either by explicitly forbidding it or criticizing it. So if I'm criticizing how you dress and how you talk and your friends, you may want to change them to please your partner. But it might be as explicit as, you must do this, and an expectation of obedience from the survivor. So this can impact things like whether or not I get medical care or have access to my finances, whether or not I can go to school or interact on social media. And control also ultimately results in the person who's causing the harm making lots of decisions without input from the partner, disregarding their wishes and their dreams and hopes. Using children and other family members as a threat is very common. If I criticize your parenting, if I say that I'm going to harm your children or family members, if you don't do what I say, it can be a very powerful tactic. And that brings us to threats and intimidation, because so often the threats, like I said, are not explicit, that the survivor is afraid that their partner is going to harm them or their family, and that can be explicit. It can be, if I can't have you, no one will. If you ever leave me, I'm going to hunt you down and hurt your family. But it can just be that there's been violence in the relationship, which makes me believe that my partner is capable of hurting me and getting what they want by any means necessary, including violence towards me. If we look at the pattern of homicides, homicides happen very frequently in domestic abuse relationships when the survivor is thinking about leaving, has made moves to leave, has filed a restraining order or a divorce, or separated from the person who was harming them. So the threat, even if it's not explicit, can be something very powerful for the survivor. Using a weapon as a threat may be an explicit pointing of a firearm, firing of a firearm, holding a knife, but it might mean, it might be a little less obvious than that. It could be every time there's an argument and a struggle over who's going to make decisions, that the abusive partner starts cleaning their gun or moving towards a weapon. The threat may also be a threat of suicide, and survivors are very in tune with what their partner, their abusive partner needs. And being afraid that their partner is going to commit suicide can be very powerful. It's also a very common experience and indicates a high level of lethality. The abusive partner may be threatening to call CPS, Child Protective Services, and have the children taken away because they're alleging that the survivor is a bad parent. It may be threats to call the police and tell the police about things that the survivor has done or accuse them of being violent. It may be a threat to call immigration. There's also an explicit and sometimes subtle assertion by the abuser that no one's going to believe the survivor, particularly that the police are not going to believe the survivor, but also that really no one else is going to believe the survivor. It may include criminal activity that the survivor is coerced into by the abusive partner, and it very frequently results in sexual violence and a dynamic where the abusive partner is saying, "You'll do this if you love me." The cycle of violence was also developed and still resonates today back in the 70s by Lenore Walker. There is lots of power to control someone if they are walking on eggshells, which is what many, many folks call it during the tension building phase. So that frequently happens before the violence. After the violence, there is frequently a reconciliation or a honeymoon phase where the abuser is behaving very lovingly towards the survivor. They may be making promises and many overtures of care and concern, which is really what the survivor wants from the relationship. There's periods of calm between these phases, and the good times between the abuse add to the survivor's belief that the abuse is solved and it's not going to continue, and that the relationship has been fixed. There's varying lengths of time between the components of the cycle, and very frequently over time, the cycle gets shorter, that abuse happens more frequently, it gets more intense, and the survivor is experiencing it sometimes without periods of honeymoon or calm periods, but are terrorized continually. Sometimes the cycle is very, very long, and the survivor is lulled into believing that there will not be violence again. The honeymoon phase is not just to apologize for the violence, but also very frequently there is manipulation in that honeymoon phase, that it is the abusive partner recognizes that the survivor may want to get out of the relationship because of the abuse, and they really want to keep them in the relationship. So it can be manipulative, and honestly, those causing the harm can feel truly bad and can be really persuasive, really really meaning it when they apologize, which is ultimately manipulating the survivor into staying in the relationship. So one of the most profound barriers to leaving an abusive relationship are the beliefs, the attitudes that blame the survivor, that minimize the danger, that don't acknowledge the harm done, that don't understand the impact. And these attitudes can come from friends, it can come from families, the attitude may be reflected in an interaction with a provider. So the impact on the survivor is really, I can handle this and I don't need to ask anyone for help. And if I do ask for help, it's really my fault it's happening, and they're going to understand the things that I've done to cause this. So I want to fix it. I want to fix the relationship. I want to fix my partner. I want to handle this on my own. Because if I talk about my experience, everyone's going to know how bad I am. And the victim blaming messages that we get in society, that people like that type of relationship, that they like the drama, that they keep going back because it's their fault, those things are a major barrier to folks getting safe. So in addition to anticipating that that folks are going to know that they're at fault, the other barriers are really two sides of the same coin. I am afraid that bad things are going to happen if I leave the person who's hurting me, and I hope that if I stay, things will get better, right? So those are two sides of the same coin. So I'm afraid that if I leave, I'm actually going to be in more danger. And as we've already discussed, that is indeed a dynamic that is all too common. I'm also afraid that my children and my other family members may not be safe because the person who's hurting me is going to punish me if I leave them. I also know that our finances are very wrapped up, and I may be financially dependent. My abuser may have caused harm to my finances or my credit report or my ability to be financially independent. I may have been relying on my partner for finances. In addition, I might be relying on my partner for caregiving. So I might not be able to go to work if I don't have someone who can watch my children while I'm there. And it may be the abusive partner who's providing that caregiving. I'm also afraid that I'm going to lose custody of my children either to the state, as we talked about earlier, if there were a CPS report. If CPS becomes aware that there's violence in the home, I'm afraid that my children may be taken. And that is a real fear. That is not an unfounded fear. And I'm also afraid because my abuser may have told me that they will take my children, either through kidnapping or through getting custody in family court, which also, both of those things also happen. They're not unfounded fears. We already talked about the judgment as at fault, or the judgment of being a failure as being a major barrier. It's also really hard to think about making a major change like leaving a relationship, particularly if I'm pregnant or recently have given birth. To be alone and as a single parent, and I may be already isolated because of the tactics of the abuse. I may be afraid I'm going to be lonely, and I may not have a really strong support network because of the isolation from that support network if I ever had one. There's also cultural and religious beliefs in keeping a family together and potential legal repercussions for lots of folks. So those threats that I talked about before that the abusive partner might make about calling the police or calling immigration, they're also not unfounded fears. And fear of involving the courts can include children's court, family court, criminal court, civil court in terms of restraining orders. They do not always protect survivors, and sometimes they do take the side of an abusive partner. So if the abusive partner has been controlling the narrative and talking about how the victim is flawed and perhaps they're engaging in behaviors in order to survive or to deal with the abuse, maybe drinking or using other substances, misusing other substances. If they don't have access to a way to support their family, all of those things can reflect badly if we're ever in court, and the abusive partner may actually prevail in those instances. So the flip side of that is that I've invested a lot in this relationship and I care about my partner and what happens to them. I want to help them to become nonviolent, to be the partner that I need. Those sincere efforts and or manipulation during the honeymoon phase have an impact on me. I believe when my partner, when they say that they're going to get help, when they say they're going to stop drinking, go to therapy, go to classes to learn how to be nonviolent. And like I said, some of those promises can be sincere. Trauma bonding and Stockholm syndrome are two dynamics, emotional dynamics that can happen. Trauma dynamic is when two people have been through something traumatic and end up with a very tight bond as a result. And sometimes that happens even if the trauma is the abuse and its aftermath and it's caused by one of the partners. Stockholm syndrome is something that we've seen in extreme instances of someone being kept captive who develops a survival strategy of believing that they want to be with the person who's harming them and holding them captive. And they identify very strongly with that person. That is a survival strategy, and we can see it in varying degrees in abusive relationships as well. It's also a survival strategy to minimize the abuse to myself and think it wasn't that bad, particularly during the periods of calm or honeymoon between the episodes of abuse, because it's really not something I want to admit even to myself, but I don't always want to admit it to others as well when they see it's happening and they try to intervene. And then, of course, I do want to have an intact family for the sake of the children, and I do have hope that whatever strategies I'm using to try to be safe are going to make the family a safe one as well. Finally, I want to give you some words from a publication called Advocacy Beyond Leaving. Advocacy Beyond Leaving is a publication that talks about how we need to think about someone's entire experience and all of the factors that impact their decision making, and all of the reasons why they may want to continue to have contact with the person that's abused them. So the quote from this publication is that battered parents make decisions for their children in the context of their lives, considering all risk factors, not just the domestic violence. For example, a battered mother might decide her child will be okay, even though he witnessed her boyfriend's controlling behavior, as long as she can put food on the table, a roof over his head, and keep him in his current school, a decision that means she'll need to stay with her current partner. So this publication was written by Jill Davies. She also wrote a book called Safety Planning, where she talks about the need for those supporting survivors to understand that there are abuse-generated risks that are considerations in decision-making, and there's also life-generated risks. So for folks who are living in poverty, who have a history of generational trauma, who have abuse as a child, who are experiencing discrimination, racism, underemployment, unstable housing, all of those things have to be acknowledged when one is trying to support someone who's being abused. We can't ignore experiences and the impact of them on folks getting safe.
Next, we will review some information about intimate partner violence and pregnancy. Pregnancy can be a happy time, waiting for the birth of your baby. Pregnancy can also certainly be a stressful time for a great many reasons. There are physical changes, emotional changes, changes to the social and family structure, and increased economic demand on families to support another individual. And research has shown that there is an increased risk for intimate partner violence during pregnancy. It's not just the 40 weeks of pregnancy in which there's an increased risk for intimate partner violence, but also the year prior to conception as well as the year after birth. It's really this entire period surrounding pregnancy when women are at increased risk statistically to experience intimate partner violence. Statistics show that intimate partner violence is experienced anywhere between 3.9 and 8.7% of all pregnancies. What does this mean for you? 1 in 20 pregnant patients that you care for is potentially experiencing intimate partner violence. Considering the number of patients typically served in a day, that means that you're likely serving multiple intimate partner violence victims daily, whether or not you're aware of it. In fact, intimate partner violence in pregnancy is actually a lot more common than many other pregnancy-related risks that are routinely screened for and monitored in healthcare settings, such as preeclampsia and placenta previa. Further, although some healthcare providers, when asked to consider screening for intimate partner violence, report feeling uncomfortable bringing up such a personal topic, patients have also been asked about their experience in many different research studies to this point, and they do not share that same concern. They don't feel uncomfortable being asked. In fact, from questions about menstruation to bowel movements to physical examinations of the cervix and the vagina, healthcare, especially healthcare surrounding pregnancy and birth, is a place where patients expect and accept highly intimate and personal questions as a part of their care. So clearly, intimate partner violence is not good for either the pregnant person or the fetus. Research has linked intimate partner violence in pregnancy to a host of adverse outcomes, including low birth weight, preterm delivery, infection, miscarriage, placental abruption, and even fetal injury and death. But it's not all bad news. Pregnancy does provide a window of opportunity of sorts. For nearly all patients, their contact with healthcare providers is at its most frequent during pregnancy. For some patients, pregnancy might actually be the only time that they are regularly accessing healthcare. Pregnancy is also a period of increased motivation in patients to attain safety and well-being. There's a desire to nurture and protect this life that's growing inside of them. There's a deep love, oftentimes, for the baby that can sometimes inspire help-seeking amongst domestic violence survivors who were not motivated to seek that help only for themselves. While we believe that survivors are worthy of safety, love, and support regardless of their status as a parent, we also recognize that we can leverage a survivor's increased motivation during this time for her well-being and that of her babies. A full review of the impacts of domestic violence on children is beyond the scope of this current training module, but We will briefly review the impacts that this experience can have on children at varying stages of development. Children experience domestic violence in many ways. They may hear a parent threaten or insult the other. They may see a parent who is angry or afraid. They may see or hear a parent physically hurt the other, cause injuries, or destroy property. They may fear that future violence or that they may become hurt themselves. When talking with survivors about their children's experience with domestic violence, sometimes we hear, yeah, what was happening, but he was just a baby, so it didn't really impact him. This unfortunately is not true. Babies' well-being and various survival is tied to the well-being and survival of their caregivers. Threats, therefore, to the caregiver's safety is interpreted by babies as direct threats to their own well-being. Negative physiological reactions to fighting amongst adults around them have been recorded in babies as young as 2 weeks old. Infants who experience domestic violence can be hard to soothe and have feeding and sleeping problems. Babies have been injured and even killed if the parent who is holding them is physically attacked. Toddlers, while still mostly nonverbal, often display behaviors and clues to their distress, such as fear, terror, clinging to the parent, or needing constant support. Physical reactions such as increased heart rate, vomiting, or loss of bowel and bladder control. They may react behaviorally by throwing tantrums and acting aggressively. They may regress developmentally, showing a loss of skills that they had mastered, such as stopping talking or losing toilet training. School-aged children can display many of these same physiological and behavioral reactions that we see in younger children. In addition, their functioning at school or with their peers may become impaired. Academic performance can suffer, as many children become preoccupied with thoughts or worries about their parents, some even doing what they can to stay at home and out of school in an attempt to be around or protect their parent who is being victimized. In addition to the many risks we've already discussed, adolescents are more likely to physically intervene in violence between their parents, sometimes being injured in the fray. As they have more independence due to their age, adolescents may show behavioral signs such as fighting with peers, skipping class, or engaging in risky behaviors like alcohol and drugs. As they enter their own dating and intimate relationships, adolescents who have witnessed domestic violence in their own homes are at increased risk for either being victimized by or perpetrating violence and abuse by themselves. Research has linked growing up in homes with domestic violence to additional risk for PTSD, anxiety and depression, cognitive impairments and academic problems, being victimized by or perpetrating violence in the future, and even involvement in the criminal justice system. We know these risks are real, but we also know that this is not destiny. Not every kid who experiences domestic violence faces these problems. In fact, many do well despite what they've experienced. So, what makes that difference? What is the most important factor in determining whether children are okay despite the hard things that they have gone through? Please take a minute to think about this question and jot down your answers. Now that you've had a minute to reflect on what you think might make the difference for children who've experienced domestic violence in their own households, I'll tell you that the answer that comes through loud and clear in research on experiencing domestic violence and adverse childhood experiences in childhood is that having a safe, consistent, protective caregiver who is in their corner makes all the difference for these children. In Ensuring that at least one parent is safe, healthy, and able to be there for their children is absolutely critical in helping children thrive in spite of what they've experienced. Supporting victims of domestic violence who are parents not only supports that adult, but also supports the children in their care. And you can play a critical role in that by identifying those who are experiencing domestic violence and connecting them to the support and resources that they need. In this last part of the virtual module, you will hear a conversation between two intimate partner violence survivors, Ms. Natalie Hayden and Ms. Shamika Washington, who have generously offered to share their lived experience and perspectives as a part of this training.
Hello, this is Erin Schubert. I am the Director of Outcomes and Evaluation at Sojourner, and I am here today as a facilitator of a conversation between both Natalie and Shamika, and I will let them introduce themselves.
Good morning. My name is Natalie Hayden. I am a community domestic violence advocate.
Good morning. I am Shamika Washington.
Good morning, ladies. Let's start off and just tell me a little bit more about yourselves. What are you passionate about? How did you get involved in this work around domestic violence?
All right. Well, my name is Shamika, like I stated. I am a mother of 5 children. I'm passionate about being a nurse. I'm in my 3rd year. I'm finishing up at MATC, and I just got accepted to Alverno and just got an actual acceptance letter yesterday with a $20,000 a year scholarship for my time that I'll be there in the nursing program. And what brought me into this particular scene was I got started as Sojourner several years ago, and I am a survivor of domestic violence. And it was brought to my attention that there wasn't a lot of outlets for us or people who were like us. So I wanted to give them that voice. And by doing this, if I can help just one person, I am extremely happy about that.
Well, like Shamika, my name is Natalie again. I am a mom as well to amazing one child, Riley. She's 11. And I am a survivor of domestic abuse, and I found my way at Sojourner 5 years ago, me and my daughter. And we were both just really taken great care of. There was a lot of support for us, and I just saw the passion. We felt the passion, and that really was just something that transferred to me into wanting to continue to be an advocate, be a voice for the voiceless. Sojourner Family Peace Center was definitely a voice in every aspect of the process for me to be able to gain my wings and be entirely free from domestic abuse. And so I felt that it was really necessary to take on that same passion and desire to help other people become free from this horrible public health crisis, domestic violence.
Great, thanks, ladies. So you're both mothers. We're going to be working in a clinic where many of the patients are becoming mothers, maybe for the first time, maybe for the 5th time, maybe for whatever time. So can you just tell us a little bit more about your family? I think you each mentioned how many kids you have, but just a little bit more about them, how old they are, what makes them special, and then sort of like what a typical day in your family life looks like.
Well, like I said, I have 5. They are 13, 8, 6, 4, and 2. And so a typical day for me is getting up by 6, get everyone up and running. I have 4 drop-offs in the morning, 1 to one school, 2 to another, 1 to another, then daycare. Then I am off to school myself. Like I stated, I'm in school for nursing. Besides that, I pick up and all of them, one of them have piano, one is in wrestling, one is basketball. So as you can imagine, I'm all over the place, but I always like to be able to take that time to journal for myself, as well as any events that's going on that give me the ability to speak to survivors on domestic violence, I'm always willing to do. So yes.
Yes,
My
so
gosh, Shamika, I have 3 drop-offs this year and I was feeling all bad for myself, but you got me beat.
man, I feel like I can't complain at all. But Riley and I, we tend to have a little bit of a busy schedule. When I have her, I have my daughter every other week. So it's week on, week off set up. But on the weeks that I definitely have her, it is really it's pretty busy because Riley is into cross country, and then I work, and many of the things that I do for the community is
Mhm.
really sort of just, like being available, as Shamika stated, to just be a voice and be an experienced almost expert in this type of work. And so a typical day really is just, me really just trying to get us out the door. I do like to take time for myself early in the morning before I leave the house, because if it doesn't happen in the morning, it's not happening.
Oh yeah.
So, so Riley is definitely a priority. So any and all
Yes.
things that I'm doing today, sharing what I'm sharing, bringing insight to better screening for intimate partner violence, and making sure children are protected as well, starting with their parents.
Yes.
She is the reason why to ensure that our children will not have to endure and incur what we have. So we're pretty busy, but I definitely like to wind down the day and sort of set some time and boundaries for us to break away from many distractions and just have time together, because that time you can never get back.
Absolutely.
Yeah. So this project that we're working on, the goal is to screen people, right? To find folks that are coming through the clinic who might be experiencing intimate partner violence, domestic abuse. So I'll ask you each to sort of think back to the time in your life when you were in an unhealthy or an abusive relationship. And was there a time when you were still in that situation that you were asked about that relationship in a medical setting or by any other professional?
Yes, I actually was. So I was pregnant during the pandemic, which was pretty tough. But my abuser was not the person I was pregnant by. And so he attacked me a day before I had to go in for a prenatal checkup, because I'm considered high risk because I have high blood pressure. And so I go, and my OB asks me a series of questions, and very calm, very patient. And I still just didn't feel safe enough to tell her what was going on, because I just felt like another number, just another patient. You got to get in, get out. It wasn't like she was able to sit down and ask me how everything was going with my pregnancy. It was more, she rushed in, want to measure my belly. And it was just like, I felt if I was able to be more comfortable, I think I would have told her, like, hey, is there some help out there for me? This is happening while I'm pregnant. What do you recommend I do? But I didn't feel it, so I just kept my mouth closed. And now I look back 2 years later, I wish I would have said something.
Mm. Yes, I know as for me, I want to say my experiences with being screened or not was, I would say I did not have many encounters being screened. I will say what was being screened was ACEs.
Hmm.
And so that's a little different. That's a different approach. I think that they're measuring something else when they're seeking for that type of screening. But had when I was pregnant with Riley, my pregnancy was actually a good part of it. I think we were in a honeymoon phase during the abuse. So things were not bad during the pregnancy. So had someone had screened for anything such as that, I think I probably would have just just turned a blind eye to it and didn't think much of it. But when I think back to afterwards, or after Riley was born, and just going for checkups and things like that, there was no screening for IPV, more so ACEs.
Mm-hmm.
Mm-hmm.
Natalie, do you think if there had been later on after Riley was born and things started getting not so great. And so do you think if somebody had asked you in a medical setting that would have been do you wish that had happened, or what do you think that difference that would have made?
I think definitely it would have made a grave difference because I do have a really great relationship with my midwife and OB and just the clinic that I'm a part of. And
Mhm.
so I would have felt extremely comfortable disclosing some serious public health issues that, you know, are going on within my personal life. And because there are many times that they've asked about other things such as, you know, STDs, that's pretty personal, you know. I don't mind disclosing and sharing about some of these things, STDs, abortions, and things like that. I should not have any problem at least for me, I would have not had any problem disclosing that I am in an unhealthy relationship and I'm not feeling safe.
Yes.
Yeah, it's interesting. You guys both talked about, I think, the importance of the relationship or the way that that conversation felt. Shamika, you said it sort of just felt almost like a checkbox, something she had to get through, another patient she had to get through. Whereas you, Natalie, you said you had a trusting relationship with your OB, so you would have been more open to that. Can you just talk a little bit more about that idea and how important the relationship can be?
Absolutely. I think having a relationship, I'll give an example, and I don't mind disclosing um, my experience personally present day, but I have not just an OB, but I have a primary. And many people do not know that your OB is not your primary, but you need a primary that can also do OB things. So I have definitely obtained a closer relationship with my primary, who is definitely now familiar after I want to say 11 years now since Riley has been born, that she understands that I was in an unhealthy relationships, which can then bring on an onset of other problems. So she's constantly asking, hey, how are your relationships? Are you in a monogamous relationship? You know, they really want to, at least my physician, my primary, she's really interested in the whole being, you know, as far as even how is the workplace relationship, and because it plays on our mental, and why am I gaining weight? Is there something that I'm dealing with? So I want to say building and fostering relationships with your patients is extremely important if you want to really get to what is really going on, the root of a patient's issues and concerns, and then we can better deal with and help rally together to support them.
Yes, and to piggyback off of you, Natalie, you're absolutely right. I feel if the room is cold, then I won't disclose. I need to feel that I'm not being rushed. I'm not just another one of your patients. You actually want to take the time and actually know absolutely what's going on with me. Like you stated, having a primary, yes. Granted, you only see me once a year for my physical and maybe a few times during the year if something's wrong. But if I've gained an excessive amount of weight or lost a lot of weight, or, you know, you just notice that I'm not looking healthier, looking great, I would like for you to feel comfortable enough to say, hey, Miss Washington, what's going on? Is everything great at home? You know, do you feel safe? Is there any resources that you may need? Like that makes a world of difference.
What I think a lot of folks that come into the medical profession get a lot of training in a lot of different areas, but domestic abuse isn't necessarily one of those areas, right? It's kind of a blind spot in a lot of people's medical education. So from your perspective, what are the most important things about domestic abuse or intimate partner violence that you feel like folks working in a medical clinic need to know?
I believe there's so much, and I do understand it's a little bit of time, but to focus on the nonverbal cues. If their spouse is always wanting to be with them, want to go in a room with them, they need blood work, or you like, hey, I need you to take, give me a urine sample. They want to follow, and it's like, okay, that should be a cue to say like, okay, let me try to get her by herself and ask her, is everything okay? I know when a medical assistant calls your name, usually for just like the weight and height before you get seated in a room, that's a great time to ask them, is everything okay? Because you can simply tell the partner, she'll be back let me just get her vitals and she'll be right back out into the waiting room. That would be the perfect time versus him being in the room and you asking a question in front of my spouse. Of course, I'm not going to say anything because they're right there. So
Mm,
just figuring out a way to ask the question when the spouse is not around.
mm. I think exactly what Shamika said, pay attention to the nonverbals, but before they can even pay attention, they need to be educated on what the nonverbal cues are.
Yes.
So if you do not have any idea what the cues are, what are we essentially looking for? So I think education is an extreme piece. Many of us have the same tools at our fingertips, and we can Google any type of signs, verbal and nonverbal, physical, non-physical, all the signs that are related to types of domestic violence. And you can even be as specific as what to look for if a patient shows up in a clinic, what those signs might look like. And really just going out and talking to other people and providing victims and, survivors of domestic abuse the opportunity to really share their story with no judgment. So I think one thing is really just education, which is what we're trying to do here today, but more importantly, have a self-vested interest in learning what domestic abuse is, because it is not just another person's issue, it's all of our issues, clearly.
Yes.
I think there's a lot of things that people don't know about domestic abuse. There's also some things that people think they know about domestic abuse that really are more like myths and misconceptions. What, from your perspective, is some things that people really misunderstand about abuse, or sort of the myths and misconceptions that you've heard?
Oh, I think there's a long list, but usually the top one I get a lot was, why didn't you leave?
And how do you respond to that?
And I simply say, it's not that easy to leave someone who is abusing you, especially when you have children, you share a home, they threaten to call CPS on you. You think of all these different scenarios playing out in your head, and it's like, I'm just better just staying here, being quiet, walking on eggshells versus rocking the boat, losing my kids, losing my job, losing my home, any stability that I may have.
Mhm.
Because it's not always that easy or that simple to leave. That's why so many women tend to stay, because it could be a financial situation. It
Mhm.
could be because they may not be legal and
Right.
they're worried about their status and getting deported and their children staying here. Like, there are many different reasons why, and every woman's situation is different.
Mm. I think many myths are, the list can go on forever, but
Yeah.
that domestic violence is just physical abuse. That domestic violence just happens to women. Domestic violence is something that is of a certain socioeconomic class, that domestic violence just looks like a certain group of people, that it lives in a certain area, that it feels a certain type of way. But domestic violence bleeds through all of those lines and barriers, or whatever we want to call it, differences, and it can find itself on anyone's doorstep. So I think when you bring down the walls of what we think or these myths that are in place, it can really allow us to do our jobs even better, become better, see people more. A person can fully and truly be seen when we don't have these blinders up of what we think domestic violence looks, feels, breathes, and looks like. So I think it's really important that we sort of put myths way to the side and unlearn and relearn, and just really educate ourselves.
Yeah.
Yeah, agreed. I like the way that you frame it as like an everybody's problem. I think you said that earlier, maybe, Natalie. And I also think that that's the power of what like universal screening can do, right? Because if it's universal, everybody gets it. And you don't have to make assumptions that like, hey, this person looks like she might be dealing with something. Let's ask her and not these 5 other women that I've seen today, right?
That's right. That's totally true because, you know, you never know. What if there's an elder person that's being abused by, you know, there's a such thing as elder abuse, and what, because she's seasoned, she must not be in a domestic violence circumstance. That's farthest from the truth. We want to make sure that everyone is taken care of, and that way, you know, you'd be surprised who will, you know, when you ask those questions, who you might be helping and saving.
Absolutely. Very well said, Natalie.
Yeah, it's the truth.
Yeah.
Yes, ma'am.
So there are a lot of reasons why when asked in a medical setting or by a professional that somebody might not want to disclose what's going on with them, right? When it comes to intimate partner violence. I think you've alluded to some of these reasons in some of your other answers already, but can you just reflect on why a victim in these circumstances might be hesitant to reveal what is going on in their circumstance?
Yes. So for me, I believe I didn't say anything because I have children, and that was my biggest concern, was them being taken away from me. The fact is, they probably wouldn't see it as I'm unable to protect my children because I'm not protecting myself.
Hmm.
And that wasn't the case. I was being abused, not my children. And I was afraid that they wouldn't see it that way. So that was really big for me. That was my biggest reason of not being able to disclose.
I want to say a victim can be just as conflicted and confused about the circumstances that they're in, and they could just not know that they are a victim of abuse. And so just really one can be shameful as to why they may not be willing to share. One can be in denial, you know, oh, that's domestic, because they think domestic abuse is just this. Well, this is what I deal with. That's not that. So, you know, that I'm not in a domestic violence relationship, or I'm not in an unhealthy relationship. He really loves me. He just doesn't want me to do this. So because it's not that, you know, and it's this, I don't identify with that. But, you know, when we open up the scope and see all the tentacles of what domestic violence truly is, that is where we can say, oh, wow, you know, even many of us or those that are in this training, you might have been in a circumstance where you may have been, unbeknownst to you, in a domestic violence, unhealthy relationship. So I think it levels the playing field. And it also helps us to understand if, oh, me, someone that is considered educated, Shamika's educated and wants better for herself and her children, can really not know that we, you know, there are some things that we just do not know. You yourself as a service care provider can find yourself in a situation unbeknownst to you, not really knowing, and you know that you're in an unhealthy relationship and you don't realize it until you're wrapped up in it. You don't realize it until you're, you know, you're pregnant and you're married.
Right. I hear what you're saying, and from an advocacy perspective, is people not identifying that they're in an unhealthy relationship themselves until something really extreme happens, right? And we see that from an advocacy perspective all the time. Like, and it's kind of ironic because a really typical phrase that many people use is, I'm actually not the typical domestic violence victim, right? Like they don't see themselves, but we hear that a lot.
Yes.
Because it's not, I don't know, it happens differently than what a lot of people's perception is. And because of that, I think that a lot of people don't identify themselves as a victim when other people might be recognizing that the dynamics of the relationship are really unhealthy.
Yes.
Yes.
So given, so Shamika, you talked about concerns about your children, concerns about mandated reporting and CPS involvement. Natalie, you talked about not seeing yourself as a victim, not seeing and recognizing that the relationship is unhealthy and therefore there isn't even anything to disclose at all.
Mhm.
Those are two really real things and really real reasons why people don't disclose, right? So with those in mind, is there anything that medical professionals or folks that working in a medical clinic could do to make it easier in with either of those situations?
Yes, I think it's being done now. The messaging that we see, I want to say just about everywhere, you know, I'll give human trafficking an example. In the airports, when you're using the restroom, there's a poster board on the back of the door and it says, "Are you safe? Are you," a ton of questions that will make someone think, and it could be the same thing for domestic violence. It is the same thing for what is domestic violence, what is an unhealthy relationship. Just really having messaging out there to just maybe send signals to all of us to say, hey, maybe you might be in a relationship that's not healthy for you. Are your children being, manipulated? Are your children, like, I think the messaging is really important, and the ante has been upped, and I do see that is something that can be, as we're doing this work, providing more messaging while a person waits in the waiting room, literature, things like that, as to educating people as they're waiting to be seen for their health about what could be, seen in, or the things that are unseen that we're dealing with, all of us are dealing with. And so because domestic violence often plays on our mental health, we're in a mental health crisis. So providing literature on what your mental health can look like being in a healthy relationship versus a non-healthy relationship. And so just really the messaging that can be provided is really important while a patient waits.
I feel that they should really educate themselves, as you stated, Natalie, and look into the laws. I want to be guaranteed, like, if you're getting me help specifically, that it doesn't concern or involve my children being taken away from me, because that's what will make me not disclose. If you can guarantee me that, like, this is something that's just meant for you, it doesn't involve your children, and just educating me to get the perspective that I need and want to get out of that unhealthy environment for me and my children.
Yep. So we talked about some things that medical staff could do to make things easier for survivors to disclose. What about the reverse? What should medical staff absolutely not do when it comes to talking to their patients about domestic abuse?
Oh, goodness. Perfect question. Thank you. I just have a few. Mine will be don't say anything in front of a spouse. That's the number one, because when I leave from you, I have to go back with this person. So whether they can from me in a car or wait till we get home, I'm going to be asked several questions, several different ways. I'm probably going to get hit a few times because, well, what did she mean by that? Asking you that in front of me. Did she know something? Did you tell her that something's going on at home? That's a big no-no. And then also for me, I will want to say is having that time, making me feel important, that you want to know, am I really safe? Don't rush. That's the biggest thing. I understand you are a provider, you are on a schedule, you have to see so many patients a day, but you taking those extra couple minutes for that one patient could mean the matter of life and death for them.
Wow, that's good, Shamika. I want to say rushing to judgment and having preconceived ideas about, just making assumptions about what they think or what a person might be going through. And I say Allow a person to, like Shanika said, allow a person the time to really speak, because that's really where a victim will become comfortable, is if, they're not feeling rushed, because this is a serious circumstance, and then taking the time. A huge no-no is not following up. Not following up and providing the follow-up is detrimental and sometimes very tragic for many. They ask me these questions, but then now what are they going to do with that information? Am I going to get the help that I really truly need? So following up is really important. So no judgment, following up, and really taking the time with a person. And so if that means, can we get you in for another appointment? And maybe have a follow-up appointment that's a little bit sooner than a normal one, just to really take a deeper dive, going the extra step to letting a patient know that you're really here for them, and that we want to, lend some more time and sort of work this out and plan together what we can do to help. I think that's really important.
Yes.
Yeah, because screening is really the first step, right? Like
Yeah.
we screen
Yeah.
for domestic violence, somebody says yes, and then a lot of other stuff is going to happen to
Yeah.
get that person to where we'd want to see them be, right?
Mhm.
So after clinic staff learns, okay, somebody, they do build enough rapport with person and a good enough relationship, and somebody feels safe enough to disclose and say, hey, this is going on in my life. What, from your perspective, are the most important things to do after that disclosure is made?
I feel Natalie hit it. Following up with me is like the number one is following up with that patient, making sure they have those proper resources, whether it's housing, clothing, knowing that they need to like get those important documents because they may want to now have the courage to leave. You want to make sure they have those passports, birth certificates, social security cards, any documentation that they may need, deeds, bank accounts, savings account, CDs, etc., things like that. I feel would be very beneficial to them. And if they need safe mailing addresses, changing to license plates, just having all those resources on hand for that particular person would definitely mean a lot.
So playing devil's advocate, if, say for instance, the hospital did not, or a clinic did not have all of those resources on deck, connecting them to someone that can ensure that they, so a proper handoff. Because I do understand that this is, this may be a cohort for many clinics. So there are going to be some points that might be missed, but one thing you can rest assured that there are service provider experts that are already doing the work. So if the clinic may fall short in providing that, they can simply just hand off and say, first of all, ask the question, do they feel comfortable with someone else being an additional support to them? So just, like asking those questions beyond me, are you comfortable with, this agency or this person or these people to help you, versus, when victims when they disclose and they open up, they're really not trying to talk to 15 different people.
Yes.
So, just being upfront and saying, hey, if there's something that I may not be able to provide for you, are you comfortable with me reaching outside of my network to this trusted resource, this source to provide you with that support? And I just think that allows victims control in the planning process for them, and to knowing what could potentially be next for them. So I think that's really important.
Right. Yeah, the handoff game in social services is a real deal, right? You get
Oh,
shoved
yes,
down the
it is.
line and
Yes,
I'll
it
give
is.
you this number. Who gives you this number?
Yeah.
But I think you make good points, like meet the needs where you can. But then if it's outside of your role, if it's outside of the resources that you have, like asking that consent, really, like, is it okay to send you to this next source that I'm thinking about?
Yes.
This is all really great. So following up with folks to see how they're doing, providing resources or connecting to resources that you might not have yourself. Take me to like the moment if somebody makes a disclosure. Do you have any suggestions around what that response can be in the moment in terms of like helpful things to say and how to respond? I'm guessing it's not like shocked, silence, clutching the pearls reaction. That would be helpful there. What, say a little bit about sort of the reaction in the moment.
I
How they
think a
respond.
reaction in the moment for me is, wow, that took a lot of courage.
Mhm.
And thank you for trusting me. And I believe you.
Yes.
Be short and simple.
Yes. Thank you, Natalie. You hit it right on the head. I'm gonna definitely piggyback off of you. That is perfect. Short and simple. We don't need, what I understand. Are you sure this is what's really happening?
Mhm.
Trust my words.
That falls
Believe.
in the do not
Yeah.
area.
Yeah. Do not category. Yes. Short and simple. And that's all I need.
Mhm.
Yes,
Yeah.
beautiful. So many of the patients at the clinic that will be serving first in this project will be pregnant. Not everybody. Some folks are coming in for annuals, some folks are coming in for other gynecological issues, but many of them will be pregnant.
Mhm.
Is there anything special to consider about pregnancy and abuse from your perspective, or if you feel comfortable sharing about your own experience in your relationships during your pregnancies?
My personal experience was I was getting badly abused while I was pregnant, my whole entire pregnancy. Of course, I didn't have to get undressed until that 8-month part when you get in check for dilation. But I mean, I don't know too many pregnant people who wear long sleeve shirts in July, and it was just like little things like that I thought would have like made my open her eyes and say something. But just like I said, the nonverbal cues, is she seeming like that she's falling too much, she's having too many accidents, you noticing like significant weight loss or just simply unhappiness on her face when she comes to see you, because it's probably not unhappiness, it's probably shame. Because
Mm.
that's definitely what I had. I had a lot of shame while I was pregnant because I'm like, I have this human being I'm carrying and I'm getting abused, and I don't know how to tell you that I'm being hurt and that I want help and I need help.
Mm. Oh, wow. I would say, can you restate the question for me
Sure.
again?
Just anything special to consider about pregnancy and abuse that you think
Oh,
is important.
yes. I think to keep in mind that moms really do want to protect their children, and they do want the pain to stop. So they want the abuse to stop. And so I just think it's really important to remind the mom that not only is her health important, but the precious child that she's carrying is feeling all of that. So what Shamika was going through, you know, I just couldn't imagine. However, I know during pregnancy, it's supposed to be a happy moment in a woman's life. And I think, like she stated, if you see someone significantly losing weight and they're just not seeming happy consistently across the visits, then those are definitely signs that, hey, maybe this mom is the mom feeling like, she doesn't want the baby, or what's going on here. Like there's a lot of red flags, I think, to pay attention to. But definitely pregnancy should be a moment where we can take the attention off the mom a little bit and
Yeah.
focus on the health of the baby. And of course, because the mom is the carrier of this child, we want all parties involved to be healthy. So I think there are a couple ways that service providers can sort of come to it when a mom is pregnant. We tend to care a little bit more about the baby than ourselves. So what are you doing to make sure that baby is good? That was what my midwife would say. So how was baby today? And not saying that she didn't care about me, but how was baby? Because I am very prideful. I'm very excited about this moment. So what am I doing to take care of the baby, i.e. taking care of myself,
Yes.
Right. Yeah, absolutely. So I'm going to ask you sort of like the rainbows and unicorn question. If you could wave your magic wand and be in an ideal world, what's each of your visions? What would a woman experience, or a man, a victim experience, as they walk into their doctor's office?
Well, I'm gonna say rainbows and unicorns really do exist for me, because at my clinic, I am acknowledged from the moment that I am at the front desk. They know me by name. So I think we're living in a time in society where, we're so distracted by so many things that we have to do that we fail to get to engage and participate in getting to, know people's name and addressing them and remembering them. And so just really being glad to see another human being taking the initiative for their health is another huge thing. And so just going into a clinic or going into a regular doctor's appointment and them just knowing without me, even before we make it back to the office, so Natalie, how was that such and such from the last conversation? That
Mhm.
means a lot to me. I have a relationship not only with my primary, but with the clinic, with the office, with the nurses and the receptionists. And so if there are things that's going on, I'm more likely going to disclose right away and not, feel like I don't know if this is a safe place for me. So relationship is just so important across the board in every area of my life. So I need not only my healthcare experience to be a healthy working type of system for me and my child, but there's other areas that I have to, work through. But I know that in a perfect world, there is no perfect world. So they're not going to always hit the mark, but for the most part, you see initiative and it's really appreciated and felt.
Absolutely. Couldn't have said it better myself. But I definitely do agree with you. When I come into whatever clinic it may be, I do want to be acknowledged. I don't want to be just another one of your patients. I want you to be able to say like, hey, how was that vacation with the kids? Or did so-and-so get their braces taken off yet? Just making that little bit extra effort goes a long way. By you having that great relationship with your patient, they are going to be more confident and they're not going to be afraid to disclose anything whatsoever, because you guys have that strong relationship. And you set that bound where it's like, you can come to me about anything. When you set the stage for your patients like that, they are going to be more than willing to step up when something is going on in their lives that's not healthy or safe for them.
Yeah.
Absolutely. I heard something the other day that people get hurt in relationships, but they also heal in relationships with other people and community with other people. And
Yes.
I feel like that is like sort of a core that I'm hearing run through this whole conversation, is like the importance of being in a relationship, being in as a part of community with other people. So
Yes, it is.
I love that. What happened I asked you about? You all have shared a lot already and a lot of really good ideas. Is there anything I haven't hit on that you want to leave us with?
I just want to say, when it comes to anyone that's taken this training, to just really let the guards down and make it really personal. And think about not just yourselves, but a significant loved one that means the world to you. And if they were sitting on something such as an unhealthy relationship, or they're being harmed, or they're being threatened, or whatever it might look like, but it's not so distant, it's very close. And as we can see with the public health issue that we're in right now, just not just in Wisconsin, but just nationwide, we are very much more similar than different. So when it comes to these stressors that we're all dealing with, I just think it's really important to bring it home and to really start having conversations with your own families about this. Hey, this is something that our clinic is trying. Have you all ever been screened before, for this? Is this normal? Have you, I just think start having a conversation with those that are close to you, and you'd be surprised. You'd be
Mhm.
surprised about the things that your parents have gone through and their parents have gone through, you know? And so it's just been something that is not talked about. It's a secret. But
Mm.
now this secret is now showing up in research
Mhm.
clinics such as this. And
Mhm.
we have to do something about it because the secret is not okay.
Yeah,
So that's what I would say.
Yeah.
yeah, absolutely. Well, thank you so very much, Natalie. And if you could take anything away from this, I would definitely say to the providers, understand you have X amount of patients, but you taking that extra initiative for that patient, each and every last one of your patients. Like Natalie stated, what if that was your sister sitting on the other end and you're asking her this? Do you rush her when she speaks about what's going on, or you're asking her a simple question? So just taking that extra time, it does definitely go a long way, making sure your patients feel comfortable with you. So if they don't disclose this visit, at the next visit when they see you, they would definitely feel more comfortable, more relaxed, and able to come to you.
Mhm. Yeah.
Right.
Mm.
Beautiful. Well, thank you all for sharing your perspective, sharing your wisdom. So many great ideas. And I think I'll say, at least for myself, I'm looking forward to interacting with all of you who are watching this and practicing and taking it to the next step.
Yes.
Absolutely. Thank you
Thank
so
you.
very much.
Thank you.